Welcome to The Road Ahead, the Future of Mobile Technologies for Global Health. It's wonderful to look out at this audience and see so many familiar faces, and yet a few new ones. I remember a time in mHealth where there were 3 of us in the entire world looking at the use of cell phones for health in developing countries. And now it is really remarkable to see just the rapid transformation that is happening in this field and the great interest in mHealth to achieve some of the real critical global health challenges that we're facing. So my name is Patty Michelle. I am the Executive Director of the mHealth Alliance. As many of you know, the mHealth Alliance was created to really serve as a global convener of the various stakeholders within the mHealth ecosystem to address some of the critical global health challenges. So really partnering with governments, with industry, with the NGO community, academics, pharmaceuticals, network operators, et-cetera, to mobilize collective action to address issues such as maternal, newborn, and child health, non-communicable diseases, HIV and AIDS, among others. And it is with great pleasure for me to be moderating this particular session because I feel that we have brought together some wonderful advocates as well as supporters of mHealth that have been engaged in this space for many years, some of them even before the issue really became as widespread as it has. So the way that this session will run is I'll introduce our speakers. Each one of them will share with you a little bit about the work that they've been doing, some of the lessons learned that they've gained, but really where they see mHealth going and what some of the critical trends that are starting to emerge in this space, particularly in developing countries. And then we'll really open it up to Q&A with all of you in an interactive discussion. So we'd like to have this be as lively and interactive as we possibly can have it. So our first speaker is Dr. Mwendwa Mwenesi, who is the mHealth National Coordinator in the Department of Policy and Planning with the Ministry of Health and Social Welfare in Tanzania. And I remember my first interaction with Dr. Mwendwa was on a phone call where she had the nerve to ask about the health outcomes. What were the health outcomes that we should be expecting from the use of mobile technology to support health? And I knew just from that moment that this was a strong champion and advocate for this space. She's been in her position since 2010, and before joining the ministry, she worked as a general practitioner with the internal medicine department at the Mumbini, is that how you say it? The Mumbini? National Hospital, and a variety of other non-governmental organizations dealing with HIV and AIDS while working as a doctor in charge of the HIV/AIDS clinic at the National Hospital. Dr. Mwenesi will be followed by Sharon D'Agostino, who is the Vice President of Corporate Citizenship at Johnson & Johnson. And Sharon is probably one of the biggest advocates in the use of mobile technology to support the health of mothers and children around the world. And it's been a real pleasure to get to know Sharon over time. Her work at Johnson & Johnson is is within and leading the work of the Johnson & Johnson Worldwide Corporate Contributions Group, and so she's been there since 2006. She's been driving the company's citizenship strategy across a broad range of corporate responsibility initiatives, including those addressing critical health issues facing women and children around the world. These efforts are also an important component of the Johnson & Johnson commitment to the United Nations Secretary General's Every Woman, Every Child campaign. Next, we'll have Lee Wells, who's the head of health programs in Africa for the Vodafone Foundation. And Lee joined the foundation to lead their health programs in 2011. He has designed and is managing the foundation's multi-million-dollar and multi-partner maternal health program in Tanzania as part of the Vodafone Foundation's Mobile for Good commitment. Previously, he was executive director of the Touch Foundation, delivering practical health system strengthening and human resources for health solutions in Tanzania, and is a former senior health policy advisor in the UK Parliament. And what I really appreciate about Lee and the work that he's been doing is that he really takes a systems approach and really thinking about what are all of the dynamic interactions that one needs to factor in when looking at the use of mobile technology strategically to support health. And I'm excited that he'll be sharing a little bit about the work that Vodafone Foundation has been doing in Tanzania to support the referral systems and some of the linkages between mobile health and mobile financing to support that work. And finally, last but not least, Jeffrey Sachs, the director of Columbia University's Earth Institute, for whom I had the pleasure of working for 4 years prior to joining the mHealth Alliance. And Jeff doesn't require a whole lot of introduction except to say that he, before anybody was looking at mobile phones as a strategic tool in accelerating the achievement of the Millennium Development Goals. So in the early 2000s, he was already talking about the transformative effect that mobile technologies were going to have, and has been a real visionary in this work. So apart from being the director of the Earth Institute, he's a Quetelet Professor of Sustainable Development. What does that mean, if you're the Quetelet Professor of Sustainable Development?
I'm trying to find out.
Okay. How does one become one of those? And Professor of Health Policy and Management at Columbia University. He is a special advisor to the United Nations Secretary General Ban Ki-moon on the Millennium Development Goals, having held the same position under former UN Secretary General Kofi Annan. He is co-founder and chief strategist of Millennium Promise Alliance and is the director of the Millennium Villages Project. For more than a quarter century, he has advised dozens of heads of state and governments on economic strategy in the Americas, Europe, Asia, Africa, and the Middle East, and is widely considered to be the world's leading expert on economic development and the fight against poverty. So I hope you will join me in a round of applause and just welcome our speakers to this discussion. And I invite Dr. Mwendwa to share some words. You're more than welcome. We can keep this very relaxed. So if I need to say,
So good afternoon again. I don't think I need to introduce myself lengthily because Patricia has already done the job. So I'll just go straight to explain actually what I'm doing, my duties back in Tanzania. As Patricia has said, I'm the mHealth National Coordinator in Tanzania, and therefore my main duties actually is to coordinate mHealth initiatives within the country, both those which are under the government and also those which are non-governmental initiatives. But also I have the role of advising the government on all issues related to mHealth and eHealth. And also, therefore, I have the role of leading and chairing all mHealth activities and meetings that take place within the country. And also one of my major roles is to work with private organizations and see how we can develop sustainable public-private partnerships in mHealth projects. And I think this is very important now, especially in Tanzania and I think in most developing countries, because we are facing the issue of having mHealth projects that the sustainability is, the future of those projects is vague, because the sustainability and especially on the funding side is not very sure, especially for the projects. But we have seen that once we have public-private kind of partnership, then the sustainability of these projects is more reliable. So in a nutshell, those are my main roles, and also I have a role of working with stakeholders who are working on mHealth within Tanzania to see how we can develop strategies and plans to guide mHealth implementation within the country. So that is in a nutshell. Yeah, thank you.
Great.
Thank you, Patty, and thank you to everyone who is here. Our briefing asked us to talk about where mHealth has been and where it's going. And I must say that I love the question about where mHealth has been, because it is a brief but very dynamic history. My personal passion and the work that we are doing and that we will talk about today is really focused on women and children and the use of mobile technology to reach new and expecting moms. I believe it's always important for us to take a moment when we have a conversation about health and we're in a conference room such as this, to think for a moment about why we're here. So today, an estimated 800 women will die, either in childbirth or in the complications of pregnancy, in just one day. That's a staggering number. This year, an estimated 3 million newborns will die in their first 28 days of life. We hear these numbers, we read these numbers in statistics. I like to think of those in terms of each family that is impacted by those deaths, each hope that dies with the death of that woman or that baby. And so the exciting possibility of mobile technology to make a difference while the world debates strengthening health systems, clearly an important issue. The debates around the number of frontline health workers, clearly an important topic. But in the meantime, we have this possibility of getting critical stage-based information to new and expecting moms. We have a history of this work at Johnson & Johnson that started actually with the internet and one of our companies, Baby Center, who has been providing information, stage-based information to new and expecting moms for 10 years and reaches 20 million women a month. But how do we reach the other women? How do we reach others? And so as part of our MDG commitment, as Patty said, we made a commitment to partnerships so that we could innovate in this space. How many of you were here for the first mHealth Summit? So a fair number of you. And at the first mHealth Summit, Johnson & Johnson announced a partnership called Text for Baby that was focused in the U.S. with the National Healthy Mothers, Healthy Babies Coalition, with Voxiva, and then since then, many, many other partners have signed on, and this is something that has taught us about taking what we know about messaging to mothers to tap into the expertise of many, many other experts, medical experts, and develop really very basic information. So that was our announcement at the first mHealth Summit. How many of you were here at the second mHealth Summit last year? So a few more, that's terrific. Between those two, we recognized that an important partnership needed to be founded for us to achieve our goals, and we are delighted with the partnership for the Mobile Alliance for Maternal Action with USAID, with the UN Foundation, with the mHealth Alliance, and with our sister, one of our organizations, Baby Center. And what we love about that partnership that was announced last year is not just that we are really very committed to getting stage-based information to new and expecting moms in low-resource settings in Bangladesh, in Africa, and in South Africa, and in India, but also because we can provide, Mama can provide, adaptable messages that can be used anywhere. And we're excited about the possibilities of reaching so many women. When I think about where mHealth is going, which I know will be part of the discussion today and in the future, I get very excited because I see a day when the mHealth Summit will no longer need to happen, because mHealth is a topic at every major conference where we are talking about health, whether it is FIGO or Women Deliver or the International AIDS Conference, that mHealth and the possibility of mHealth will be part of every discussion so that we are innovating and learning from each other to form partnerships that really will save and improve lives. Thank you.
Great, thank you.
Afternoon, everybody. At the Vodafone Foundation this year, we've been asking ourselves two principal questions in thinking about mHealth, mainly in relation to our programs in maternal health in sub-Saharan Africa, and thinking particularly about fragile health systems. The first is thinking about those patients and health workers in the villages and district hospitals, many of which, as you may know, will have only one doctor. They may be 80 nurses short, and the ability to refer between centres is very limited. And with that human resource shortage, it's pretty difficult for them to think about data collection. So are we actually distracting people from their job of saving lives in order to collect data for us without them necessarily seeing an immediate return? So in other words, thinking about the whole of the healthcare system as they experience it at the district level. The second is, given the need for scale and sustainability, surely partnerships are not just helpful but essential, and that's something that's been uppermost in our minds in terms of creating meaningful partnerships, principally in Tanzania and including the Ministry of Health, and we're very fortunate the President's Office, President Kikwete. So in addition to our support of the mHealth Alliance, our principal mHealth work has been working in Tanzania, and we've been grappling with some of these issues. And our involvement on the ground really began at the CCBRT Disability Hospital in Dar es Salaam, which you may be familiar with. It's one of the largest providers of fistula repair, obstetric fistula repair in the country. I'm not sure how much you would know about fistula, but there are around 3,000 new cases of fistula in Tanzania each year. One of the problems is the size of the country. There are, I believe, 45 million people. I should actually check. 45 million people spread over a country the same size as France, Germany, and the Low Countries combined, with something in the region of 2,500 doctors. So it's very, very rural. However, there was extra capacity that CCBRT had in Dar es Salaam to be able to provide fistula surgeries. The difficulty was finding the women. As you may know, fistula marginalizes women in so many different ways, emotionally, psychologically, economically, and as Dr. Mwemwa was reminding us earlier before the panel started, also in terms of the way it affects the whole family unit in terms of the way children are cared for, etc. So even with free treatment that CCBRT were offering, there was no way for the women to get to Dar es Salaam to access that. So one of the directors at CCBRT, I would like to say that it was somebody at the foundation that came up with this idea. It wasn't. It was a young director, came up with the idea of using M-Pesa, as that was the mobile money scheme, as that was more and more available across the country. And anybody that's travelled in Kenya or Tanzania, you'll know that you can find the little duka, the little outlet outside of every hospital, on every street. It's pretty ubiquitous at this point. He realized that if they had ambassadors searching out these women in the rural areas, they could identify the women that needed the surgery, call a hotline, which they created, to book an appointment, and then be sent the money for the ticket, which is a minimal cost, but often more than the women themselves can afford in order to access the treatment. Once the woman arrives and has been met by the CCBRT staff, a small incentive payment, a tiny percentage of the overall cost of treatment, is returned to the ambassador to say, thank you very much, please go and find somebody else. And I should say that the most successful ambassador in Tanzania at the moment for this particular program is a cleaner in one of the district hospitals, because she often is meeting the women who are being told, well, unfortunately nothing can be done here, and she's able to sort of access them, and she's very, very active. And of course the next stage is to make sure that the women are ambassadors themselves. So we've started to put together, I should say that the senior executives were presented with this last year, this case which we were supporting in a relatively modest way, and they became very enthusiastic, not only about the use of the technology, but obviously the effect, the dramatic effect that this, combined with the treatment that CCBRT were providing, could have for these women. We've, since this year, been putting together a multi-million-dollar, multi-partner program with the support of President Kikwete. And what we're attempting to do is to translate that model of referral, that text-to-treatment, as we've been calling it internally, model, and making it more available for maternal health in rural areas. And that's really, perhaps to sum up, where we're at the moment. It won't be a surprise for you to know that no matter how smart your smartphone is, it can't deliver a baby. I realise this is breaking news, and please remember you heard it here first. But what it can do is provide that linkage, as we've already seen with a chronic condition such as fistula, but also then in maternal health, in preventing maternal death and disability, and that's what we're aiming at now. But of course, just the technology applied singly can't be effective. We need to make sure that the community healthcare workers are there in the villages and that they're trained appropriately to be able to identify the women that are going to be at risk, needing emergency caesareans, at risk of obstructive labour or difficult labours. We also then need to make sure that as you refer somebody, you're not referring them to a place which is incapable of coping. So we also need the district hospitals to be better staffed. The great news is that Tanzania has been doing a very good job recently of training more and more doctors. And there are now a sort of a critical mass that can be made available together, and there are various programs, the Touch Foundation is providing one of them, made available at the district hospital. So I suppose my plea is that of the things that we do, we try to ensure that the technology is applied, but it has to be a systems approach. We recognise that the mobile phone can't do it all. And just finally to say, I'm not anti-collecting data, please don't misquote me. I think it's important, but I think we can be much smarter to make sure that we're collecting it as we're helping people to do their jobs, rather than collecting data as their job. Thanks.
Well, I'm sorry to break the news to Lee, but my phone delivers babies. He has last month's model, and you know, I think the pace of improvement is so striking that we will see remarkable and unpredictable applications continuing to develop, and the integration that Lee just told us of payments and helping to get women in need into the care delivery is a great example of that kind of integration. Mobile is wonderful for systems integration. Information is at the essence of systems integration, and this, I think, is where we will head on many, many fronts. Patty asked me to reflect very briefly on where we've been to get to where we are today, and with some idea of where we're going. And I can most simply remember that when the Millennium Villages project started in 2005 in 10 countries, there were no phones anywhere. There were no landline phones, and there were no mobile phones. Everything that has come since then has been a revolution of technology and capacity. I don't know how we ever dreamt we could do that project without phones or email, but thank God within about a year connectivity began, partly because in the specific of the project Ericsson helped to bring it in, but more generally this was the great wave of uptake. And to appreciate how dramatic all of this is, it was in 1990 when there were only about 10 million mobile subscribers in the world. Now it's well over 6 billion. It certainly is the most rapid diffusion of any technology in world history. So this is a revolution that we're watching and partaking in as we speak. Of course, it's part of a more general revolution. I like to call it Moore's economy for Moore's law. It's not only mobile, but it's every part of the digital revolution. The ability to handle, store, transmit, process information has improved roughly a billionfold since 1960. And we have not improved a billionfold in the applications of all of that, except to stream movies and other things. But we will improve dramatically, and mHealth is part of that overall revolution. When you think about what this technology offers, I just made a very quick list of things that are underway but are not there yet at scale or systems integration. First is the empowerment of community health workers, which is a fundamental aspect of healthcare delivery in low-income settings. And by the way, will become a fundamental aspect of health delivery in the United States when we ever get around to health reform. Because a lot of the functions right now that go through the high-priced health system will go through the community instead. And we will learn a lot from the experiences that are underway in Africa or India or elsewhere to bring them finally back to the United States. Second will be more general systems integration, whether it's payments, referrals, transmission of patient information and so forth. This is obviously all necessary and yet still on its way. Electronic medical records as part of that. Another thing that will absolutely explode, it's happening, but it hasn't happened yet in a big way, and Lee's example is an illustration of that, is patient involvement in their own care. So the ability of patients to reach out to doctors, the ability of health workers to reach out to patients, patient monitoring at a distance. This is now becoming pervasive. New instruments, new appliances to take blood pressure or to monitor other aspects of temperature or other aspects of patients' well-being through microprocessors and mobile communications will be absolutely central and normal. Diagnostics are improving phenomenally because of the digital revolution, directly and indirectly. The fact that malaria can now be diagnosed without a lab, but just with a drop of blood, is one of the most significant advances in public health certainly in this generation. And there are a lot more diagnostics like that to come. Emergency response is obvious. Simply being able to call an ambulance ought to be something available to every person in the world. It isn't yet, but within 10 years it will be, and we should help to ensure that that happens. Epidemic surveillance will be a major part of this. We have a lot of smart systems now, Google-based systems and others that are reading texts and reading words. Probably they shouldn't be reading everything we're writing, but they're picking up signals that say there must be an epidemic going on here. The behavior of the texters is different, or a keyword has shown up repeatedly, or this kind of search is being done. This suggests an influenza epidemic or a malaria epidemic or some other kind of outbreak. Of course, telemedicine is already in application in some high-income settings and in a very, very few selected low-income settings. But when broadband becomes more pervasive, telemedicine also will become more pervasive. You need a much bigger pipeline of data to be able to use telemedicine effectively, but it's on its way. We know from Jeopardy show Watson that artificial intelligence health systems are on their way, and this also will be something that will become more widely available, and it won't have to be in high-income countries alone. A World Wide Web and a lot of broadband mean that those systems can be deployable, based anywhere and deployed anywhere else. Infrastructure is getting a lot smarter through, for example, prepay electricity, which is a way to take the same business model that has led to 6 billion mobile subscribers and now to reach a couple billion people who don't have electricity. And so off-grid solar power, for example, will become a much bigger theme, I believe, based on prepay, new financing systems, and the monitoring that goes along with that. That's a mobile application. Supply chain management is obviously a system need that is ideally suited for technologies of all kinds, because goods are on the move. You want to know where they are. You want the barcodes to pass through the detection. You want to know where your medicines or your vaccines or your other supply chain attributes are. And also facilities monitoring, so that stockouts and other facilities issues and maintenance of facilities. Is the water running? Are the toilets flushing? Are the computers online? Is the electricity working? These are all things that can be monitored from afar now, and that is a huge application on its way as well. So my take on this is that we're still in the very early days of the mHealth and digital revolution in general. We will see huge breakthroughs in Africa, in South Asia, and other low-income settings. Those breakthroughs will eventually become breakthroughs in the United States when we finally get around to addressing a healthcare system that's at least 2 times more expensive than it ought to be, and that will free up perhaps $750 billion a year for other things than the waste that is now part of our healthcare system. Finally, what I see as the most strategic single step right now in this area is empowering community health workers with the mobile systems on smartphones. Mobile and community health workers together can absolutely be a profound step change in healthcare delivery in any low-income setting. But it's not simply a matter of having a health worker. You need a little system, a little ecosystem to make it work. The health workers need to be trained. They need to be empowered with phones. There needs to be support of the industry, the telecom providers, to make sure that the bandwidth and the other technical facilitation is available. There needs to be good software writing and sharing of that software so that we spread best practices and best techniques. And governments need to understand what a great revolution is at hand if they'll grab it. And I'm so happy to know that President Kikwete and Tanzania are grabbing it. And I'd like to see every country in Africa say this is the moment for us to scale up mHealth empowered community health workers, because this is the single most important thing that can be done right now to accelerate the achievement of the Millennium Development Goals.
So I want to thank each of you. That was a wonderful, very complimentary view of where mHealth has been and where we're going. Oftentimes, when people talk about mHealth, and this started as early as 2003 when the first definition of mHealth came from a biomedical engineer at Kingston University, Robert Estepanian, and he reflected on moving towards citizen-centered healthcare. And what does that mean? What does that mean to move towards citizen-centered healthcare? And each of you have, to some extent really touched on this. Like, how do we provide the types of services or access to people when and where they need it the most, whether it comes through a community health worker that's empowered or through direct messaging through platforms and services like MAMA. And then from a government perspective, I mean, your role ultimately is to make sure that your population is healthy, can really thrive and grow, and then linking and making sure that people can sort of get the transportation, get all the different pieces together so that they can get the health care they need. And so I would love I will kick off with the first question and then open it up to questions and answers from the questions from the audience to the panelists. But what, out of all the different pieces that you've just talked about, in terms of empowering individuals, where do you see things going? And what is that going to mean in terms of all the policies that need to be put into place or the collaborations that need to be put into place to make sure that we're really meeting the needs of people? Dr. Manuel, do you want to?
Yeah. Thank you very much, Patricia. I think you have touched a very important thing, especially to developing countries, about how can we touch the people with these mHealth services. Actually, in Tanzania, most of the people who are affected by poor services, like no access to services, are those who are marginalized and in places which are hard to reach. You may find healthy facilities there, but probably the healthy facilities do not have healthcare workers that are needed. A facility probably is providing delivery services, but there are no skilled midwives to help in birth deliveries. So mHealth services, actually they can help and they can reach these people. For example, in Tanzania we have a program that is under the Ministry of Health and Social Welfare, whereby we have introduced the use of mobile phones in the healthy facilities in the most remote villages, and we are now in the process of scaling that system. But basically, what the system is doing is that the healthcare worker who is in a healthy facility can use the mobile phone to report, and in case of there is a maternal emergency. For example, if there is a woman who needs to be referred from the facility, she or he can use that mobile phone to communicate with the district hospital that there is an emergency woman who is being referred, and probably that midwife or that healthcare worker can also receive instructions, probably what she should do while the woman is being transferred, because probably the woman is bleeding. And just transferring the woman to the district healthy care without providing the basic first aid services, the woman will not reach the district hospital. So while the woman is moving from the healthy facility in the remote village to the district, the healthcare is able to communicate along the way, and probably she will get instructions what she can do. Open the veins, put make the veins open, so those instructions are very important, and they save the lives of women. And also, this system also is used to report on diseases of outbreaks. So in a healthy facility, previously, when there is an outbreak of a disease, for example, cholera, it was paper-based. The healthy care had to write, probably report, and close the healthy facility, maybe walk 50 kilometers to the district to report that there is an outbreak, because usually they need help from the district in order for them to manage the outbreak. So these kind of services, actually they are touching the community, and they are helping, in saving lives, actually. Yeah. Thank you.
Sharon, a lot of the heart and soul of the work that Johnson & Johnson supports is trying to get targeted stage-based messaging to pregnant women and new mothers. So.
Yes, and I believe it's very important to acknowledge that what Dr. Mwenda has said and Dr. Sachs has said about the importance of information being in the hands of frontline health workers, community health workers, is absolutely critical. What is also critical is to empower individuals with information. And we see this as not just a health solution, but an empowerment solution, especially for women. And because, as I said earlier, I believe it's important for us to think about who that individual is, and you will be very familiar with this video, but there is a brief video that interviews a mother in Bangladesh, and her name is Asha Rani, and she talks about the fact that she wasn't a first-time mother, which many people recognize that first-time mothers need information. She was a second-time mother, but what she talked about was the fact that her first baby was often sick, and the information that she was getting was from her mother-in-law and her husband, based on local lore. And she says, through the translator, I did not know what I didn't know. With her second baby, her baby is healthy, and she can take her mobile phone and she can show it to her mother-in-law and to her husband. She has information, and that empowers her, and she has now become the central point of the decisions for that family's health. That kind of empowerment is what mHealth can do.
Great. Lee?
I'm minded to give an example that didn't happen to me, but a close friend. In fact, the head of our foundation was in Egypt recently, and looking at an education-based platform that we were supporting. And an elderly woman was there taking the course, and it was about promoting literacy. And Andrew said, well, what have you got out of this program? Why is it useful? And she said, well, it's given me two things. One is the ability that I can now sit with my grandchildren and help them read. And the second one is I can now read my husband's text messages. And she winked. So I thought that for me was the very personal bit. But that's lighthearted. I think there's one of the ways in which, and I'm pleased to see Eric from Switchboard here, in terms of the work that they're doing with closed user groups with doctors and other healthcare workers, that for me is particularly exciting. In a previous life, when I was working with a team from Touch and McKinsey & Company, we were asking in northern Tanzania healthcare workers, why is it that you don't stay within the healthcare system? Often they will stay within sort of para-healthcare systems, but not there. They say, well, there's no clinical network. We're sort of parachuted behind enemy lines, the conditions are pretty bad, and we've got nobody to call upon, whether it's for just basics, sort of human-to-human support, or whether it's for sort of clinical decision-making. So those sorts of technologies, I think, are ultimately very personal. I mean, we talk about the sort of the retention of the healthcare workers, but it's actually, transforming the experience of them providing medicine. And then finally, I would just say, in terms of I'm minded to think of this sort of that ecosystem, and how do you have something that's managed? In terms of ambulatory care, we know that it's not very widely available. I visited a hospital, Bukoba, in northern Tanzania. They had 5 ambulances, none of them worked. They'd worked for the first couple of years, they were broken down, the servicing was very expensive, they couldn't keep them. But parked outside of the gate were 15 taxi drivers. I know it's 15 because I counted them. All there ready to take people backwards and forwards. Part of what we're looking to do now is how do you harness M-Pesa so that the community healthcare workers can call upon those taxi drivers and utilise them whether in out of hours. It's not going to take a vast amount of money, but it does take a system and some management. And at least in this instance, that's something that we're looking to try and sort of demonstrate how that can be done. But certainly it can be replicated and very cost effectively. Thank you.
Great. And Jeff, you talk a lot about health workers, but what about moving towards individual citizens, and what can we do in some ways to complement the work of health workers by empowering people themselves to take better care of themselves?
I think there's no question that the individual revolution will be a major part of this, and in the context that we've been working, it wasn't really right for that at the beginning because the penetration of cell phones was very small at the start, and you could say, let's make sure that there's one at the clinic, one with the ambulance, one with each health worker. But now, because cell phone penetration is rising so dramatically, the communication directly with an individual is extremely important for a clinic to be able to say, it's your antenatal visit time, these are the results, and so forth, is a revolution in the life of these villages, because one of the defining aspects of extreme poverty is isolation in terms of distance and isolation in terms of information, and this is certainly overcoming the isolation in terms of information, or has the potential. I don't think, though, that we're going to completely individualize healthcare. We really need health systems. And that means that we need that ecosystem of workers in the community, from the community. We will still need clinics, we will still need hospitals, we will need drivers, and so forth. And knitting that together has been elusive. I'm hearing, though, so many wonderful examples of how that's now being done. And I think we're at a point where sometimes a network starts with just a few pieces, and then graph theory says that all of a sudden it becomes a universally connected, completely connected graph. And we're just at this moment of near complete connection of the graph. But we have to do this in an orderly way. Where I don't mean orderly in the sense that be so careful, but I mean in a thoughtful way where the government says, we're doing a big scaling up, and the partners say, we understand, we're going to help you do this across the districts of the country, and it proceeds with some scale in mind, now that the pieces are there but are not yet fully connected.
Great. So thank you for that. Do we have any questions from members of the audience? If you could just come up and introduce yourself and speak into the microphone, that would be great.
Good afternoon, ladies and gentlemen. My name is Eugene. I'm from Nigeria, National Primary Health Care Development Agency. My question is that in Africa, in Nigeria, we know that we're doing a whole lot as regards mHealth. But oftentimes, what we have from firms and organizations that are offering solutions is that they're bringing things to us that are not compatible. It's a little kind of disturbing, because in modern ICT, you can pick your phone and call any network. That means that there's connectivity amongst the networks across the globe. But when you offer mHealth solutions to an existing country that, a group that already has an existing system and you cannot integrate it into the developing technologies, then it's creating a system. I'm thinking that a forum like this, where you have all the solution providers or all the practitioners in one place, we will be thinking of how that will be done so that you don't have standalone projects, several standalone projects in one small community. How do we actually have such an integration? Thank you.
Great. Thank you. Does somebody want to tackle that one? Jeff, I know we've encountered some of those issues with the villages and.
Well, I think that in Nigeria in particular, this is a good time for a national strategy, and Dr. Pate, the minister, is interested in leading that. We need to encourage him and backstop any gaps in that. But I think that there is a sense now that this is important for the scale of the country to put these pieces together, and I think Nigeria really could do that and would get good returns from that.
Thank you very much. I think you have touched a very important point, and there is where I think the government comes on board. And in Tanzania, the situation is not different from Nigeria, and I'm sure from most of the developing countries and African countries, we are facing the same situation. So on my point of view, I think also the government has a role to play in making sure that there is some coordination of these mHealth, whether they're systems or projects or programs. And that is when we say that having national policies and guidelines on e-health in general, not only mHealth, is very critical. Because I think this should come from the government. Then the other stakeholders can be involved, but there need to be a champion who can lead this process. Yeah.
Obviously I work for the foundation, but if my commercial colleagues were here, I'm fairly sure they gave me a little pep talk before I came, and I'm fairly sure they would be saying, in many countries where you have these individual, and it's natural given where we are in terms of the state of mHealth, I think the various individual platforms, you can still have an architecture that you put in place that enables each of these to talk together, and maybe it's a case of going to the provider of your choice as a government to have that program in place to connect these together. I know that Vodafone has the mezzanine platform developed in South Africa, which enables that in terms of whether it's sort of patient data, whether it's management of individual healthcare workers, those different platforms that can be plugged in and tailored together, which kind of takes a little bit of the pressure off of those, the platform providers perhaps. As you can tell, I am not a mobile systems expert.
Thanks, Lee. David?
Before I ask this question, I'm going to say I share the optimism of the panel about particularly the impact on community health workers. With that said, we are going to make massive investments in helping those community health workers, and they desperately need it. We're working on a project where there's 487 clinics in Uganda who don't have clean water. So you can imagine being a community health worker who doesn't have clean water at the clinic she works at. But my question is, at what point does that investment need to take into account that those community health workers generally are not paid? And how do you sequence the investment so that maybe ahead of the fanciest next new tool, some kind of women's economic development is done in the community that enables a small percentage of funds from those successful efforts to be funneled back to paying the community health workers? We see a social enterprise in Uganda that's working on this approach with women farmers, where they would then pay a percentage back to fund the community health workers that would support them. So how do we get to the point, and how does the government and the NGOs and all these different people who are involved somehow make a decision, because otherwise we're going to way overinvest in tools, and we're going to have all these unpaid heroes who just can't possibly do the job without being paid.
Jeff, I know you've been a strong advocate on this for a very long time, and we're just now starting to see some real momentum building on this front. Do you want to take that one?
Community health workers need to be professional. They need to be paid. They need to be trained. They need to be equipped. Their backpack has to have diagnostics, ACTs for malaria control, a wristband for the MUAC, an armband to measure children's arm circumference, oral rehydration, and many other things. This is a professional service. It can be done by people in the community, but it's a career. And the idea that this is going to be done on a voluntary basis misunderstands what a health system is in a village, or what an effective health system is. So we need to scale up the outlays on this. It's not a lot. The estimates are that a community health worker system is on the order of $5 or $6 per covered person per year. It's manageable, but not necessarily manageable within the budgets of impoverished countries. So for the most impoverished countries, we have the Global Fund, we have Gavi, we have the World Bank, we have PEPFAR, we have other agencies. They ought to be investing in community health workers so that governments can scale them up. And fortunately, I think there's a lot of interest in that, but it hasn't been organized yet. So this is absolutely, in my view, on the agenda right now. We have a great global health leader as head of the World Bank. Good time for the World Bank to step forward and say it's going to fund community health workers. We have now Mark Dybul, who did a spectacular job at PEPFAR, now head of the Global Fund. Very good time for the Global Fund to say, now we're going to finance community health workers. And this would enable governments exactly to step forward and say, all this wonderful opportunity, we're moving forward, and we have some backing to do it. So your question is spot on. There is no way other than normal, paid, salary-trained workers. Now we can get it done with this mix of domestic and international finance.
Okay, I think we're going to have to wrap up the session, but what I would like to do is take the last three questions in quick succession and then throw it to the panel for one last round of responses. In the back, you were there first?
Yes, my name is Mitzi Sellers with Green Mesh Limited, a cloud-based software and services provider. I'm wondering how much, whether it's NGOs or ministries of health or donors, should plan to spend to be able to afford a rolled out national system of the kinds that you've been talking about.
Gladys?
Me?
Yes?
Well, thank you very much. I was really impressed about the experience that you have already shared with us. But I have a real important question from my point of view. I am in Mexico. I am from the National Institute of Public Health in Mexico. And when I hear all this experience, the big question that I ask myself is what about the legislation of the community, the connectivity in the countries? Because in Mexico we have a real problem. And I don't think that the mobile technology now is really equitable. I think I would like to hear from you if it's really just you think and you believe that this technology is equitable now, because we have a legislation that makes the access of the mobile health very expensive. And exactly the poor people and the people who is more far from the urban centers don't have, they have the phone, absolutely, but for 5 minutes, because the cost of the 5 minutes is so high that they can use 5 minutes. And this is a very real problem. So what we can do with that. In Latin America, I think most of the countries has the problem of the legislation. I don't know in Africa, but how this system is now supported, because I think it's a real problem for us.
Yeah, no, that is a real problem. And then the last one, I don't know if we'll actually be able, I think there's another group that needs to come into this room after.
I can make it very quick.
Sure.
My name is Shmit Luhar. Thank you very much. And the question that I have is really around healthcare law and healthcare policy. And I think everyone in the room will agree that bureaucratics and law here in the United States sometimes makes it very difficult for mobile technologies to become very accessible just because of HIPAA regulations, PHI restrictions, so forth. And I'm interested in hearing some of your experiences across in other countries where those countries have been able to overcome those barriers and see mobile technologies become so successful.
Great. Thank you for those questions. Does somebody want to take a quick pass at answering one or any of them? I think we're going to actually have to leave. What is the time on this one? Okay. I think you will do that. Lee, do you want to take a quick pass?
Very quick pass. In terms of the cost of a national system, I can get you the number of somebody that will tell you. I guess it depends what you want in the system. In terms of the lady from Mexico, Dr. Mwenwa and I were discussing before about the cost of calls. She and I were both bemoaning the fact that to make a call from here to Tanzania, our $10 didn't last but for a few seconds, but she was describing how a relative could put 1,500 shillings on her phone in Tanzania and call here and got at least 5 minutes. So there are clearly solutions that are workable.
Great. I want to take a moment to really thank our panelists for the great work and sorry for the complex. There's so much to talk about. And thank you for joining us. Enjoy the rest of the conference.